let me introduce our guest tonight, Dr. Michael Myers. He is a professor of clinical psychiatry at SUNY Downstate Health Sciences University. He's a recent past vice chair of education and director of training at the Department of Psychology, or Psychiatry and Behavioral Sciences. And he is a specialist in physician health. As a clinician, a doctor's doctor, a researcher, writer, mentor, lecturer, and consultant. And he is the author or co-author of 9 books, most of which are about and for physicians and their families. He's also a past president of the New York City chapter of the American Foundation for Suicide Prevention. And that's a small group, was founded by a small group of families affected by suicide loss and a team of researchers in 1987. And he's also a recipient of many national and international awards and was honored with a presidential commendation from the American Psychiatric Association in 2022 for his clinical research, teaching, and advocacy in suicide. Dr. Myers became a survivor of suicide loss at the age of 19 when his roommate Bill, a fellow medical student, took his life. So, Dr. Myers, thank you for being here and for sharing your wisdom and experience with us. I will turn it over to you.
Okay. Amanda, thank you very much. I really appreciate the introduction and the warm welcome. Thank you, everybody, for coming. I want to thank the group also for inviting me. Okay, that's my disclosure slide. And these are my learning objectives. I'm hoping by the end of the time with me and after the discussion that we'll have a better sense of some of the things that can lead to suicide and suicide attempts in physicians. I'm going to talk quite a lot about stigma because it's really, really so important. I'm going to talk about a skill set for all of us to use when we're worried about a colleague and to reach out to them. Things like that can be life-saving. And then just a few things about self-care and working on resilience in ourselves. So I want you to know, for instance, that there's not one kind of suicide, and that pertains in doctors as well. There's so many different subtypes. So I'm going to talk in generalities and maybe more specifically during the Q&A. But generally, this is kind of suicidology 101, that we believe that, close to 85 to 90% have been living with some type of mental illness, often unrecognized, undiagnosed, et cetera, et cetera. And so obviously it can't be treated when it's not recognized or diagnosed. Or in physicians, what I find is that even if it's undiagnosed, though, sometimes physicians will treat themselves, which is very, very hard to do. Again, that's usually rooted in stigma. They may be undertreated or mistreated. And also, again, because of stigma, sometimes when a suicidal physician goes to a health professional for care, there's such a complicated dynamic going on that they may not get the same quality of care that they would if they were not a physician. So let me just go over this quickly because it's kind of more psychiatry, but the things though that can put us at risk. So mood disorders are number one, and that includes, of course, depression, unipolar depression, as well as bipolar illness, bipolar 1 and 2. I say possibly burnout because the jury is out on this. There's so much research going on. Many people believe that somebody who does die by suicide, who has been burned out, that has morphed into something out of DSM, but it's not fully sorted out. But what we do know, though, is that there's overlap, and there's a big difference, though, between straightforward burnout and major depressive disorder. Anxiety disorders, often underreported and underrecognized too. They can be very severe and can cause people to panic and to take their life. PTSD, again, kind of a sleeper. I mean, we've always sort of diagnosed it in military physicians, but it took quite a while before it was recognized that a lot of the day-to-day work that we do in medicine can be traumatic. And so it's now more recognized and then gets properly treated. Don't forget medical disorders, especially the progressive ones, neurological disorders, that can put physicians at risk of suicide because they really do not want to live with this medical illness any longer. And then the personality disorders and things like that. Those are the three most common that I've seen in my practice: individuals with narcissistic, antisocial, and or borderline traits. Okay, so this is what I mean, and this is kind of one type about becoming suicidal. So this is why I use that verb, a process. It's not an event. It just doesn't suddenly hit you, although it can appear that way. But it's often been going on for a while, and the substrate is this biopsychosocial mix that we don't often know about. The individual himself or herself may not really know, but that's why we look for family histories of major psychiatric illness, and in particular, any suicidal activity or behavior in family members, or death by suicide in family members, trauma, psychological things in childhood and later. Cultural dynamics really come into play, and I'll talk about those in just a minute. So what can happen then is the so-called perfect storm, and it's horrific. And it comes over the person. It's overwhelming. They're desperate, and all they can think about is some type of immediate relief. In some, it builds slowly over time, and then there's a last straw that puts them over the edge. But as I said there, it's terrifying. And then there's another group who have been depressed, and these are often doctors on medical leave, and their illnesses are nasty, and they may get back to work part-time for a while, but then that doesn't work, and then they're kind of lose their identity. They lose a lot, and those are physicians with more of a chronic illness. And for those individuals, they really do think about suicide as a comfort and as a relief, that they want to end the pain that they've been in for so long. So this sort of gives you just a little bit of sense of this. The reason why I and others who do post-mention research know this is because I've interviewed so many families of doctors who have died by suicide, and I get their observations and what they saw. And I've also interviewed quite a large cohort now of physicians, mostly in North America, but some in Europe as well, who have made near lethal suicide attempts and did not die. So they're able to report what their mental state was just prior to taking that desperate action. So why specifically in doctors? Well, there's a lot of generalities, but there's three things that can put us at risk. Our knowledge of toxicology, and we pick that up even before medical school, often in the basic sciences or foundation years. And so a sort of sense of what we could use to end our lives. Huge lethality here. Not all physicians who die by suicide use a medical means, but a number do. Because, and again, having looked after so many suicidal doctors, so many of them will say to me, and if I do it, I'm going to do it right. I don't want to botch it. I've looked after too many botched suicide attempts in my work as an intensivist or as an emergency doc or as a psychiatrist. So there's another group, of course, who have access to things, who are like potassium chloride, syringes, intravenous apparatus, chemicals, things that can be taken from hospital or clinic settings to be used in preparing for death. And then something called acquired capability, and this is the work of Thomas Joyner, who's a very prominent psychologist and suicidologist. And he believes that there's a subset of physicians who become sort of almost inured to death and no longer feel kind of frightened by it. And he specifically mentions trauma surgeons, emergency docs, psychiatrists who are exposed to a lot. Okay, so what other things though? Well, these are the ones that are familiar, I'm sure, to most of you, the perfectionism. And as you know, that's a double-edged sword, okay? We have to be somewhat perfectionistic to even get into medical school, and then to maintain our good performance through the residency and then beyond, and not get in trouble, et cetera, et cetera. But it can be our downfall as well if we can't cut ourselves any slack. So that's very, very important. And it can be a precursor to depression. So it has to be looked for and it can be treated. Now, what about altruism? Taking better care of our patients and others than ourselves. And I say self-neglect without judgment. So I'm going to tell you the story of Dr. Stone. This is a disguised patient of mine from my book on physician suicide. So Dr. Stone, a 56-year-old internist, came to see me within days of being named in a lawsuit. The patient was a woman he had treated for many years, someone whom he thought was happy with her medical care. I'm here because last weekend I decided I've got two choices, he told me, to shoot myself and get it over with, or to see a psychiatrist. I'm just kidding, Doc, is what he said. Don't take me seriously. I'm not going to kill myself. You don't have to lock me up. End of quote. But I did take him seriously, of course. He wasn't suicidal, nor did he own a firearm, but he was certainly very unhappy, defeated, and sad. And he was very angry and bitter. I quote him again, I've given my whole fucking life to medicine, and what have I got out of the deal? End of quote. He was tired from decades of 12-hour days, Monday through Friday, and half days on Saturday. He'd been an athlete in college, in medical school, and he had let his nutrition and fitness fly out the window over the years. In fact, he even brought in his graduation photo for me to see to illustrate his point. So he's sitting opposite me, and I saw him looking at this picture as he had showed it to me. And then he said this, I don't even recognize that handsome, cool ass dude. End of quote. I sat quietly and listened to his sobs. I continued to listen and listen for many visits until he began to feel better and to reclaim his life. So that's about altruism biting you in the butt, so to speak. What about the dogged need for autonomy and trouble asking for help? Remember, there are a lot of people who study medicine have come from families where they're kind of self-starters and they've done a lot of this just on their own. And they're used to being pretty self-sufficient. So it's hard to reach out for help. They see it as a flaw or weakness as opposed to the smart thing to do. And what about poor treatment adherence? Because that's said about us a lot, that we don't make very good patients. And I would argue that, having looked after hundreds and hundreds of doctors, I can tell you it's hard to be a good patient. It's because of stigma, because of the work that we do, all kinds of things. And so whenever I'm sort of consulting with a young psychiatrist and they're saying, this patient, this doctor patient is really driving me nuts. I say, okay, let's get to the bottom of that. Let's see what's going on. Let's try to figure that out. Okay, what about other things like the culture of medicine? And this is particularly noticed during training, the so-called hidden curriculum that all of you are familiar with and will remember, the survival of the fittest. It's sort of kind of seen, or maybe not always stated, but yet. By the way, there used to be a time when deans would welcome incoming medical students with statements like this, welcome to medicine, you're the best and the brightest. I was on record of going around telling deans not to welcome the students like that. Welcome them warmly. But don't tell them they're the best and the brightest, because of course they're not. They're best and bright people all over in graduate school and stuff like that. But that puts an enormous kind of burden on them and stuff like that. Bullying. It's with us and still with us in medical school and residency, sexual harassment. There is a need for a Me Too movement in medicine. It's still there. There's still a lot of stuff. I'm the ombudsperson for our medical students at Downstate. I also serve on the Learning Environment Committee. So a lot of this stuff is very familiar to me as sort of individuals that can kind of sit on top of something that the individual are already struggling with. And the so-called microaggressions that we see in ethnic, racial, and sexual minority physicians. And what about the loss of agency and moral injury? I'm going to talk about that in the next slide. Those are drivers of burnout. And then let's face it, we all know there are huge systemic pressures in today's medical world. It's all over the place. We know that. So So how is moral injury different from burnout? Okay, we weren't talking about moral injury until about probably 10 years ago. Originally, again, from the military, but also nurses started talking about this before we did as physicians. If you look over to the left, you see these stressors and the double binds that people get in. That causes somebody in medicine to have moral distress. Then if it doesn't go away, that can kind of morph into moral residue. It kind of sits in your gut. And then moral injury, where you do feel traumatized and injured by having to work in a setting that is so against your principles. And then you get into burnout where there's loss of agency. You feel like a cog in a wheel. The one thing I like about this graphic is you can see in the finer print, it says personal, family, health, and substance. Those are all stressors as well. And they get kind of left out at times when we're talking about burnout. And the reason I say that is that, I lecture so much in burnout, and you talk to burnout physicians, they're the first place they blame, of course, is the work setting, because it is an occupational definition. But yet some will say, but it's not just that. I've got a mess going on at home. My marriage is awful. One of my kids was picked up for shoplifting, and others got trouble with drug use. So they've got those strains and stressors on them as well. This is a book I would highly recommend by Dr. Wendy Dean. We had her come and give a grand rounds in the Department of Psychiatry about a year and a half ago, and she's done this book with Simon Talbot, and they are the founders of I would say, the moral injury movement in North America. And this book is really wonderful. And Daniel Offrey, as many of you will recognize and know her name, she's just such an important figure and wonderful doctor, by the way. I love what she said here. And she doesn't pull any punches when she talks about thumb screws applied to medical professionals by their corporate overlords. Makes it impossible to do the right thing for patients, and profit-hungry system casually gouges the moral fiber of healthcare workers. By the way, she has an op-ed piece that was online over the weekend and last week, but it's in the print edition of the New York Times. It's either today or in the Sunday edition. I urge you to read this, especially as she's saying now, with the threat of people being forced out of the country, that we have a responsibility as physicians, those of us who look after undocumented immigrants, for instance, to speak out. She's such an advocate of advocacy, thank goodness. So here's a reflection question. I just like to pause a minute and just kind of think about the big picture here. And this has to do with implicit bias. There's so many things, for instance, language, literacy, et cetera, et cetera. So how might clinician implicit bias impact a non-binary, gender fluid medical student? And by the way, this is a disguised thing from my work as an ombuds person. Listening to their senior attending laughing behind the back of a suicidal trans patient in the emergency room. This happened with regard to a student, non-binary student, listening to a psychiatrist actually laughing behind the back of a suicidal trans patient. So these are the kinds of things that we all have to be thinking of, especially as our world keeps changing. Let me move on to stigma. I realize I'm going over this quickly, but we'll have time in the discussion. So to break it down into external, and there's these other names, enacted, exterior, et cetera. Internal, that's what we feel inside. Okay, and I'm going to compare and contrast these. So enacted stigma, so that's the outside stuff, okay? It's discrimination against people with a psychiatric illness because they're perceived unacceptable or inferior. Let me tell you, this is from my blog. These things are all on my website. This is 2025, but there is still a lot of discrimination in medicine against people living with a psychiatric illness. There is this sort of sense of, and you're going to have another reflection question a little bit later, unacceptable or inferior. And this is why so many individuals are really nervous to go get help, this type of thing, because you hear about this. And this occurs in selection processes when people are applying for residency, and also for jobs. It's a lot better, by the way, than it was, but we still haven't eradicated it yet. So here's a real example, and this has to do with credentialing, okay? Both for medical license applications and hospital credentialing applications. So there's kind of three groups here that have published on this. There's the Katie Gold group from Michigan, and her colleagues. And then the second one is one that I signed on to. And what we did is we looked at all of the medical licensure applications across the country back. And so it's about 8 years ago, and found that many of them violated the Americans with Disabilities Act, the way they asked questions about mental illness of people applying for a medical license in their states. Now, we've come a long way since then, but there's still too many states asking outdated and dangerous questions. And then Lisette Derby, who was with the Mayo group, has now moved to Colorado. And you will know her name, of course, from all the burnout literature. And so there's another group looking at medical licensure and credentialing as well. So let's talk about culture for a minute, okay? Because see, that varies as well. There are many individuals who are petrified to even tell family members that they're seeing a psychiatrist or a psychologist or whatever. And so it depends on whether you're first generation, second generation, religious beliefs. There's just all kinds of things. These are, what we call, of course, the social determinants of health, social determinants of mental illness as well. And stigma, by the way, can be on a continuum. That's one of the things that I've sort of noticed, that when I look after somebody, when they first come, they feel dreadful. They've got both internal and external stigma, but when they get feeling better, they don't feel so ashamed. Thank goodness. So, but you can see why any of you who treat physicians would see sometimes why they don't like to come to see you, or why they're not very good with their medication and things like that, because every pill is a reminder. Every visit is a reminder of what they think is that they're less than or flawed. So let me turn now to felt stigma. That's the interior stuff, that is stuff we feel inside. It's pretty yucky, a sense of diminishment. And in that blog piece, part 3, I did that. And also my next book, which is coming out this year, is on physicians with lived experience and how their stories offer clinical guidance. I interviewed the parents. Dr. Sophie Spooner was a young physician in the UK who took her life about 7 years ago. And she had been diagnosed with depression in medical school, and she sort of kind of got around that and got used to it, but later was diagnosed with bipolar 2 illness. And she was never really able to come to terms with it, because it just seemed such a burden to her, with so much loss having to do with being married, having children, getting through residency, in her case, pediatrics. And also, too, the care that she was getting was kind of sporadic. And I've recommended to all psychiatrists and other mental health professionals, when they're looking after any young person who has been given this diagnosis, the continuity of care is absolutely critical, because it takes anywhere from, I would say, 3 to 5 years. It's a little bit, any of you who have diagnosed a juvenile with diabetes, you know how long it takes them to get their head around being diabetic. Well, it's similar, with our young colleagues in medicine too. So here are some examples of felt stigma. Okay, that's what you're feeling inside. This is why we deny things. I mean, who wants to see something that's stigmatized in yourself? So, or we minimize it, that, I don't think I'm drinking that much, maybe a little bit more than 5 years ago, but, I don't think I'm an alcoholic. Or magical thinking. Some people think if I work harder, then maybe I'll feel better. Hesitancy to reach out, they delay, choking embarrassment, particularly, that sort of thing, and lying to those entrusted with your care. I just get used to that. To me, I just don't judge. It's just part of these are not easy illnesses to have. And And so I have to kind of read between the lines and just see that there's a discrepancy between maybe what my patient is telling me and the way I see them objectively. So I say this all the time. I don't know how many publications I've said stigma in the house of medicine is pernicious. I use a very strong word. It's higher in our profession than in the general population, and that's why we're reluctant to get help. Why we struggle with the treatment alliance, and it makes us sicker. That's the heightened morbidity, and of course puts us at risk of killing ourselves. Here's another example from my book as well. And this is a surgeon who I was looking after, who I'd seen her for a couple of months actually. And this is in intensive care unit where I'm talking with her. And this was about an hour after she began to wake up from a near fatal suicide attempt by overdose. And so I'm sort of just doing a back and forth. So this is me speaking. Do you know where you are? And she responds, yes, I'm in an ICU somewhere. And I say, correct. Do you know what happened? And then she says this, I sure do. I took too many pills. I wanted to die. I mean, I want to die. I said to her, I'm glad you didn't. I'm happy you survived. Listen to what she said to me. You are? I'm so embarrassed. I feel ashamed of myself. I said to her, don't be. You're in a good place here. Nobody's judging you. The staff here just wants you to get better. Then she says this, but I really blew it. What kind of surgeon can't even kill herself properly? I was stunned when I heard her say that. So I kind of got this response. This is what came up for me because I knew her. And I thought, I think I can risk a little bit of humor here. And here's what I said to her. And I put in parentheses, taking a risk and attempting some humor. I said to her, I didn't realize that knowing how to kill yourself was a requirement of the American Board of Surgery. She looked at me, smiled slightly, which I was so touched by. It was so nice to see her smile after being so, sick and comatose. And then she said to me, good one, doc. That meant a lot. Then I said to her, get a bit more rest. Then you and I have got some work to do. Your depression is still there. It's got to be treated. We'll keep you safe here until you're feeling better. And what had happened is that she was stockpiling the medication that I had prescribed for her and just telling me that she seemed to be improving, but because she was just so against taking medication. So after this, then she became, much more treatment adherent, took her medication. I put her on medical leave. She did really very well. So let me turn to all of you and to all of us. Things that we can do, okay? For those of you who don't have a primary care physician, please get one. And let that person be your doctor. And for those of you who are the primary care physicians to other doctors, I hope that you're comfortable in that role because it makes it so much easier when you are, because then your patient, your doctor patient will be comfortable. So as you know, you have to take charge without being bossy or authoritarian. And you have to watch your boundaries. But then when you're the patient and you've got a doctor looking after you, then you don't have to waste your time self-diagnosing and self-prescribing. In my the study I'm referring to there is my postvention study of the one I mentioned earlier, talking with their families. Most of them did not have a primary care physician who died by suicide. Okay. Fighting the stigma. Okay. We can all do that. Seeking mental health care initially is embarrassing for most doctors. But in many cases, once you feel better, that's what I said. Consider coming out about it. Tell your colleague about it, extended family, or trainees. You don't maybe need to go completely public with it, but if you feel so moved, you could tell somebody and just tell them, and you will feel better and they will as well. I think it's wonderful role modeling for us, those of us who teach, those of us who are training the next generation. It's a gift because we are helping them. They already have us on a pedestal. And so now they can see that we're human too. And it makes it much easier for them in their hour of need to go get help themselves. Let me tell you about Rahab Gupta. Wonderful, wonderful young doctor. She's now completed her training as in private practice in Southern California. Her piece in JAMA was just unbelievable. When I read it, I solemnly share, I got in touch with her, and she had also produced this short 4-minute videotape. I use that a lot in my teaching with medical students and with residents. It's called Physicians Connected. And she's worked with me at a couple of presentations at the American Psychiatric Association, and she's very committed to fighting stigma in training. And Adam Hill, that name may be familiar to some of you, when he wrote this piece in the New England Journal of Medicine, and he writes here, I have a history of depression and suicidal ideation. I'm a recovering alcoholic. But look what he added. He had moved, and then this new state, and disclosed my history of mental health treatment. The licensing board asked me to write a public letter discussing my treatment. Can you imagine? Talk about external stigma and discrimination. As he said, an archaic practice of public shaming. Then he said this, we're all responsible for this shaming, and it's up to us to stop it. We are, because doctors serve on those committees, licensing board committees and everything. So everybody has to have this kind of what I would call an empathic experience. If they haven't been ill themselves, a lot of empathic experience with physicians who have been this type of thing. Anyway, he's a wonderful guy, has also written a great book too. I think it's called Out of the Woods or something like that. I urge you to read it. He's moved now. He's a pediatric palliative care physician. He was in Indiana for many years, and he's in Colorado. Here's another reflection question, okay? So that's the preamble like before. So how might clinician implicit bias impact the hiring of a new applicant who's disclosed living with bipolar illness and substance use disorder, but it's in sustained remission? Okay, two people competing for the same job or for the same residency spot. One supposedly has this sort of squeaky clean mental health history, as far as we know, because not everybody discloses that, but another one who does, and they just put it out there, frankly, living with. So could there be an implicit bias where you think, I don't know, it could be a lot of work. Wonder if they, have a flare up or something, things like that. So if you're ever in conversation where you hear people talking like that, please try to speak up. I think you'll feel better for it. Let me talk now about reaching out to each other, our brothers and sisters keepers, okay? Because are you concerned about a colleague, for instance? This would be somebody that you work with, but they seem out of sorts recently, the last few weeks. And those would be some of the things that perhaps you notice. You think, alcohol, drugs, depression, PTSD, eating disorder. Then I add here, whatever you do, do something. I don't want you to regret not doing something. Some people will tell somebody else who's maybe closer to them, and between the two of them, they'll decide, I think I'll reach out to her because I know her better, that sort of thing. But at least do something about it. Don't just sort of walk away. Because I talk about universal precautions, and those of you who were around in the days as those of us of a certain age, remember universal precautions? We just assume that anybody coming into the emergency room or under our care could be HIV positive or whatever, that sort of thing. And the same happens with psychiatric illness, because we have a work persona, that we cover up an inner wobbly state. We have to sometimes just to do our work. And I want to recommend this 4-minute film, Make the Difference, Preventing Medical Trainees Suicide. I won't take the time to show it tonight. It's on YouTube. And Amanda has put it in the chat. But I urge you to have a look at it, even if you're no longer in training. There's so many tips there, and I'll tell you what they are. what I call life-saving messages. When we put this video together through the American Foundation for Suicide Prevention and the Mayo Clinic, we worked really hard on packing as much as we could into 4 minutes. But these are some of the take-home messages that getting stressed during training, of course, is normal, can happen to anyone. Don't hesitate to ask them if they're okay and ask straight out about suicide. There's a myth. It goes back to adolescence, is that if we ask about suicide, we might precipitate suicide or a suicide attempt. That couldn't be further from the truth. Most people welcome you noticing and reaching out to them. In this video, you get some language of what to say, and most importantly, what not to say. Because sometimes in our attempt to reassure someone, we say the wrong thing and they feel dismissed, actually. Then it goes through what to do next. And the take-home message, asking for help, is the smart thing to do, the professional thing to do. Any of you in leadership roles, okay? You've got to deliver some potentially upsetting news, never on a Friday, okay? Or before a long weekend. And never if you're heading off on vacation that you're not even going to be around. And especially if the recipient is completely isolated or alone. I know so much of this from having been in leadership, especially as a former training director. When we're having to talk with a resident about remediation, probation, or possibly dismissal, the support of the chief residents is key. If there are family members who can be of support, these are blows to somebody in training, and we have to, be as empathic as we possibly can be, with something like this, which is, very hard news for them to take. So being our brothers and sisters keeper is a moral imperative. I do feel that's really part of the Hippocratic Oath. So we've got to watch for, reach out to them. And I always tell people that your vigilance is not intrusive or crossing boundaries. It's got to do with kindness and caring that you've noticed. And you could be overreacting or whatever, but let them know that. And we really do reduce morbidity and sometimes saving a life. Now, I can tell you, I can sit here and say that I've lost count of the number of doctors I've looked after in my career, especially ones in recovery from, well, either a psychotic illness or recovery from substance use disorders, particularly cocaine, ketamine, um, particularly highly addictive drugs, who will say that they wouldn't be alive today if it weren't for their colleagues at work reaching out to them. And they mean that very, very deeply. Some of them say, I was furious, but I realize now I had no insight, or the insight I had was so minimal. I thought I was fooling everybody when I was on a really downhill course and so close. I would not have survived. And I'm so grateful to be alive today. Those are the kinds of things, like such gratitude to their colleagues. Okay, so what can we do? Well, as best we can, pay attention to these dimensions of health. As we know, good health is not just absence of disease. It's being in good spiritual health, emotional health, et cetera, et cetera. What about feedback from our family, colleagues, and patients about our well-being and behavior? By the way, I put patients in there because sometimes patients will offer advice to doctors that they know well. One of the things I learned in my postvention research, in addition to talking with family members of doctors who had taken their lives, I also talked with patients who had lost their doctor to suicide. These individuals were absolutely devastated. And some of them looking back thought, I thought the last time I saw her, she just seemed different than before, but I didn't say anything because I thought it's not my place. I'm just her patient, but I wish I would have said something, that sort of thing. So we all got to do this together. Now, those of you who are in relationships or have families and you get defensive, okay, well, wait till you're not defensive and then listen, because you have to, I think, go by the premise that your family members do love you and care about you. And this is why they're taking the courage to speak to you. So Talk to others about how you're feeling. Try not to isolate. Could be a good friend. Got to put yourself first. Don't blame yourself for feelings of burnout. As I told you, it's systemic. It's an occupational definition. And it's got to do with the way medicine is structured today. We didn't have this, by the way, 30 years ago. We had other things, but and these are the basic things. Okay, our rest and sleep and exercise, primary care doctors I mentioned. Don't let any job in medicine severely compromise your right to a personal and family life. This is why some people leave certain jobs. This is why some doctors leave certain specialties, because they feel this is just killing me. Collegial relationships, the Ballant groups that were so popular in the 60s, the late 60s by, I forget it, Enid, Michael and Enid Ballant, UK physicians, were meant to be support groups for difficult patients, but now they're kind of meant as narrative medicine groups and to support each other. And all of these other things, mindfulness, meditation, lots of CBT strategies that really, really work. By the way, this 188 number is very, very important. This was started by a woman psychiatrist in Philadelphia at the very beginning of the pandemic, and she's kept it going. And I interviewed her and wrote a blog piece on her as well. She has somewhere around 750 or 800 psychiatrists all over the country who volunteer on this physician support line, which goes 7 days a week. And it's about 12 hours a day, or maybe a little bit more. I put it up here because sometimes people don't want to call anybody locally. They're so concerned about their privacy. They don't know who might be at the other end of the line. So that's a good number to have should you be in crisis. And I can't finish up today without talking about Lorna Breen and her death. And then, of course, the unbelievable work of her sister Jennifer, her brother-in-law Corey, and the Dr. Lorna Breen Law, which has been passed. It needs to be renewed. And the work that they're doing on licensure and credentialing. And this is just an example from their website. They've got these toolkits about getting places up to speed. These individuals are absolutely amazing. They're determined that something good is going to come out of Lorna's premature death by suicide. It's a complex outcome, many drivers of risk. I just tried to capture this. This is a paper that Dr. Moutier from AFSP and the FICE and Sid Zusick put together. It was sort of like getting toward the end of midway through the pandemic when we put this, but it was basically to just explain, that suicide is complex, but yet can be prevented a lot of the time, not always. But Dr. Murthy, by the way, there's many things I like about him, but here's one right here that he talks himself about. It's not when we feel we can't let our colleagues know if we're not okay, a feeling that millions of health workers, including me, have had during our careers. So I thought that's very good transparency that the Surgeon General is able to admit vulnerability like any other health professional. Here's your take-home points. Another tip of the hat to another Surgeon General, David Satcher, because he really put suicide on the map. Suicide prevention is everyone's business. That's all of us here tonight. Okay? Don't hesitate to reach out, et cetera, et cetera. Practice self-compassion. I want to thank Drs. Heinen and Alicia for inviting me to be here tonight. All my colleagues and mentors and patients and students, there are so many people who inspire me. And many generous health professionals who have shared their personal stories. They educate all of us about human vulnerability. That's my phone number, my email, and my website, where I try to keep lots of stuff up to date and available for people.